So it's going to pull all the liquid, mushy stool that's getting stuck in those pockets and kind of bind it into one big log. And so you have
Mm.
less of a chance of stool being stuck in the pockets, less of a chance of infection, less diverticulitis.
Literally, you're full of shit. Like, literally.
Yes, exactly. The information shared on this podcast is for general educational purposes only and reflects the host's personal views and experiences. It does not constitute medical, legal, or financial advice, and no professional relationship is formed by listening to this podcast. As always, consult your own qualified advisors regarding your specific needs and practice. Thank you.
Hey, Dr. Soyka.
Hi, Sonia.
Hello. So today is our last episode for season 1.
I was just going to say that. I was going to say, do you know what today is?
It is. It's our last episode for season 1. For those of you who've been with us all this time, thank you. We really appreciate it. Spread the word to your loved ones, to other patients, to other physicians, to have a look, to listen, or to just have a good chuckle. And we appreciate you. I'm wearing my world-class colonoscopies enthusiast shirt today. I don't know if you can see it, but a shout out to World Class. They're with us at Scrubs and Heels. They create funny, witty wardrobe for people like us who are all about the gut health.
Exactly. And a little better than a postcard of someone's butt.
I mean, if you want to send me a postcard this summer of like a sneak peek of your tushy, I'll take it. Like whatever you want to send.
We're really losing it. I think the episode quality, just we are rolling down the hill.
Unhinged. That's
Unhinged,
okay.
yeah.
It's
I mean, it's
okay.
just our true self, so
That's
it's
the scary thing.
that's what you signed up for, people, once you pressed play.
Today we're going to be talking about something that I have no clue about. Diverticular disease. So I guess first, what the heck is diverticular? Let's start with that. Where is it? What is it? How is it? Give me an anatomy lesson.
All right. So, diverticula are pockets, essentially outpouchings. And they can happen anywhere in the bowel. So like I like to say in the past, anywhere from the mouth to the anus, right? So esophagus, small intestine, colon, but they're much more prevalent in the colon. And they're essentially areas of the wall. You know, if you picture your colon as, a muscular tube, I like to tell people, like, think of it almost like like those squishy toys, like Neatos and stuff like that, that the kids have now. Or do you remember, like, back when I was a kid in the 80s, there was that thing, like, it was like a toy where you put your hand on it and like all the pins and needles went
Yeah.
over it, and your so it's like as if you stick your finger, you push it in, and it makes like a indentation, like a little outpouching essentially. So it's
Okay.
like a pocket, like a kangaroo pocket essentially.
Okay.
Now, that in and of itself is not bad. It's just that the wall gets a little bit weaker because it's not like
Mm.
straight down anymore. You have like a pocket there. And um, they're very common. So, so the presence of diverticula in the colon, at least, is called diverticulosis. Okay, so if you have diverticula, you have diverticulosis. Now, lots of times people tell me that they have diverticulitis,
Right.
and I like to tell them, like, no, you don't have chronically have diverticulitis. Diverticulosis is the presence of the pockets. Itis
Mm.
is when they get infected. Itis is, in medicine, we like Latin words, right? Like
Mm.
appendicitis, laryngitis, conjunctivitis. Itis means infection or inflammation.
Mm.
Colitis, for example. Um,
Mm.
and so inflammation and or infection is when you have diverticulitis, but for the most part, it's just osis, which is the presence of them.
All right. I was going to crack a joke. Pockets is something women don't have in jeans. It's something we all wish we had in our pants, in our jeans, like dudes.
In our dresses.
Yeah. Like, at least I know you can get them in your colon if you can't get them on your jeans.
Yeah. The problem is your colon doesn't like to store stuff in them, especially shit. So, diverticula in and of themselves are not bad. But the more you have, the more likely they are to cause problems. And the two main problems are bleeding and infection. And so bleeding's kind of easy to discuss. It's basically, the wall is thinner. You only have one wall, right, of your bowel. So if you push it out and you're stretching it, you can imagine the wall gets thinner. And there's blood vessels coursing all the way through the lining of your intestine. So if you stretch that, the blood vessels get really close to the surface. And they can, if something scratches it the wrong way or whatever, they can just randomly bleed. And they're it's like crazy. They bleed super fast, super bad, and then generally just stop on their own.
So they just stretch too much and they start getting angry and bleed. Okay.
Yes. That's not something, if you have a diverticular bleed, you need to go to the emergency room. It's not something that would happen chronically. People come to me, with occasional bright red blood per rectum when they wipe or things like that, or blood mixed in the stool. That's not a diverticular bleed. A diverticular bleed is like gushing blood. You're going to the hospital. Yeah, really, it's scary, scary stuff.
Okay, gushing blood, whoosh.
Yeah, take notes of that. Gushing blood.
Okay. So as soon as you say gushing blood from your anus, you have to go to the ER.
Yes.
Okay.
It could be diverticular bleed. It could be other things, but, it could be like an ulcer that's bleeding super fast. But there's definitely reasons to go to the emergency room.
Okay. And then the second thing you said was an infection.
Right. So this is the big hot topic, is diverticulitis, which is infection of diverticula. And back in the day, we used to think that when stuff like food particles got stuck in the pockets, that's what caused diverticulitis. So we used to tell people, don't eat seeds, don't eat nuts, don't eat flax, stuff that can get stuck. Don't eat popcorn. Popcorn was a big one, right?
Yeah.
Because it can get stuck in the pocket and cause diverticulitis. But there was a big study 10 years ago. And it was thousands, tens of thousands of people with diverticulosis. And they put them on a restricted diet of nuts and seeds and that kind of thing and popcorn, and just a regular diet. And there was literally no difference in rates of diverticulitis.
Oh.
So that's not the cause.
It's kind of I know you and I are both having toothageddon, dental challenges, so much fun. But we have little pockets between our gums, right? And they keep telling us to clean, make sure food doesn't get caught there. So originally the theory is that seeds and stuff could get caught in these pockets and it wasn't good for you.
Yes. So they thought if the seeds and stuff get stuck in it, that's what we call a nidus of infection. That's the reason that the pockets are getting infected, because food is getting stuck in them.
Okay.
But that study proved that that's not the case, right? Because people that were restricting their diets of all of those things still were getting diverticulitis and or not getting diverticulitis. So then the question was, what does cause it? And probably the most likely answer to that is, one, if you've had it before, you're much more likely to get it again. So the more times you get diverticulitis, the more worrisome it is that you will get it again.
So history.
The second thing is that it probably is what gets stuck in the pocket, but it's probably not food particles, it's probably stool. And so we know that patients that are constipated and have diverticular disease have a much higher rate of diverticulitis, because stool is kind of pushing its way, mushing itself into those pockets.
Mm.
And then when you have a bowel movement, it doesn't all come out. And so what I recommend for patients, especially if they have diverticulosis or they have had a history of diverticulitis, I recommend a fiber supplement like we've talked about in episodes before, especially, I mean, I particularly like a soluble fiber supplement, but it can be insoluble too. But the point is, what that does is it bulks the stool. So it's going to
Mm.
pull all the liquid, mushy stool that's getting stuck in those pockets and kind of bind it into one big log. And so you have
Mm.
less of a chance of stool being stuck in the pockets, less of a chance of infection, less diverticulitis.
Literally, you're full of shit. Like, literally.
Yes, exactly. And so I remind people, like, if they say like, oh well, I already take Miralax, you know, and I'm like, okay, Miralax is not a fiber. All it's doing is keeping you regular, which is good because we don't. I just said we don't want you to get constipated, but it's not bulking the stool. So, and one is not for the other. So you can try, adding a fiber supplement on its or substituting your Miralax for a fiber supplement, but it's probably not going to work. You'll probably end up needing both.
Remind the listeners of some of your favorite fiber supplements if they didn't listen to previous episodes.
Yeah, so I love soluble fiber supplements, and really a little goes a long way. People, if you look at the containers, sometimes these fiber supplements are like, take 400 cups, and I'm like, this is ridiculous. Like, who's taking this much fiber? I think the really 2 teaspoons once a day is generally enough. Sometimes people can get by with even one, but I really don't think more than 2 teaspoons once a day is needed.
Is there soluble fiber that you dig?
I generally say like Benefiber or Citracel. There's also a fiber powder called Regular Girl, which I recommend a lot because it has pre and probiotic in it, which I think is nice. And it's like a nice, clean, like no additives to it, vegan. But there's a lot of those on the market. But
Okay.
generally, looking for a soluble fiber supplement, just a little bit.
Okay. So how do you get diagnosed with diverticulitis if you don't have the gush of blood?
But
Like,
remember, the gush of blood is not diverticulitis.
right. Sorry.
It's
That's
just,
like go to the hospital immediately. What's the, how do you, is it through a scope? Is it through endoscopy? What do y'all do?
so that's a great question. So actually, diverticulitis can be diagnosed clinically. So you can come to my office and say, these are the most common symptoms. Abdominal pain, and it's almost always in the left lower quadrant
Yeah.
because that's where the majority of the diverticula are, in that portion of the colon in the left lower quadrant called the sigmoid colon, because that part of the colon is the most windy. It's a little bit of a S shape or a spiral, and because of its shape, it's at baseline already stretched out a little bit, and so it's much more prone to diverticula developing. So but you can get diverticulitis anywhere. I mean, you can get diverticulitis in your middle of your small bowel if you have a diverticula there. But generally, it happens down in the colon because that's where stool is and that's where stool's getting stuck, etc. Okay, moving on.
Abdominal
Left lower
pain.
quadrant abdominal pain.
Yeah.
Many times you will have a fever because it's an infection, right? So you'll get a fever or clammy, feeling fatigued. The other thing you can get is a change in your bowel habits. So, when you have diverticulitis, there's a swelling that happens in that area. So it can causes like a relative narrowing of your colon. And so you get a change in your bowel habits. Many times people will have a lot of diarrhea from the inflammation. You can even have some blood, but not like gushing Mount Vesuvius. We're just talking like, a little bit. So if you come into my office and you say like, I have a fever and abdominal pain and I feel your belly and there's like, very, really tender to touch in the left lower quadrant, especially if I know you have a history, Like that's diverticulitis until proven otherwise. If you're
Mm.
not sure, you can the best test is a CAT scan. So a CAT scan is the best way to know if you have diverticulitis or not, if you can't tell clinically.
Yeah, I think when I was in no man's land figuring out a diagnosis, some people would, some of my GPs were like, oh, you have diverticulitis because I had fatigue. I had pain in the lower left quadrant, but we hadn't diagnosed me yet with ulcerative colitis. But it just seemed like, oh, yeah, it must be that. Must be that. And I'm
Well,
like,
it's
well,
certainly more common.
how do we know? And we know, okay, by doing a CAT scan. And what's the best way to treat it?
So we used to think that it just was like antibiotics all the time, every time. But
Oh,
it's actually, there's a lot of data that's been coming out over the last 5 to 10 years about trying to start treatment of diverticulitis with just diet. So what we tell people is go on a clear liquid diet. So many times people will have like a mild, right? Like they have like a little bit of pain down there, no fever, but they've had diverticulitis before, they feel like it's starting up. And in an effort to sort of not develop antibiotic resistance and not risk you getting other infections like C. diff and things like that and decreasing your immune system, we don't love to give people antibiotics all the time, right?
mm.
And so we say, okay, if we think you're sort of have a mild case, you can actually try to treat it just by going on a clear liquid diet for 24 hours. And if things get remarkably better, then slowly, reintroduce regular diet.
So that's like broth, soups, clear, anything you would do for a colonoscopy prep, like clear liquid.
Exactly.
Okay.
Jello, popsicles, lemon ice, bone
Oh,
broth, chicken broth.
okay. So clear liquid diet, if for 24 hours, that's another remedy. What
But I
else?
mean, the mainstay of therapy is antibiotics. It still is. It's
Mm.
the tried and true. Usually, there's two kind of common regimens because they cover GI organisms or bugs. So one of the more common ones is ciprofloxacin and
Yeah.
metronidazole, which is Flagyl. And
What's
then
flagell?
Flagyl is
Yeah.
metronidazole. It's two antibiotics, so ciprofloxacin and metronidazole. But the brand name of metronidazole is
It's
Flagyl.
flagell.
I don't
Okay.
even think it's a brand anymore. It's like been generic for years, but we all know it as Flagyl for whatever reason.
Flagell. Okay. So Cipro, I know. So
But you have to
Cipro
do them
flagell.
together. Together.
Oh. So you're like double fisting antibiotics.
Yeah, it's like a bar.
A little cocktail.
It's so fun. The other is Augmentin, which is like amoxicillin clavulanate. So those are the two probably best first line treatments for diverticulitis. And then we recommend a colonoscopy after an event of diverticulitis if you haven't had one recently. And the reason is to try to see, is there a reason that you got diverticulitis? Or are you experiencing a mimicker like, you, Sonia, where it was like, is there actually ulcerative colitis going on? Or is there a big polyp that's sort of blocking one of these pockets that's making it get
Mm.
infected? Sometimes we find small cancers that are doing that. So, you know, we recommend a colonoscopy, but not immediately. Because remember how I said there was a lot of swelling and inflammation? So
You want
that's
it to
going
cool
to,
down.
exactly. So we usually say
Yeah.
6 to 8 weeks after the episode.
Okay. Speaking of double fisting, a dream of mine as a patient.
Here we
I
go.
know. So random. It's like when I'd go every 28 days for my Remicade infusions. Like I would sit there, I would try to do work. Then one time Sandra couldn't get my vein and she's gotten my vein every time, but I was misbehaving. I wasn't focused. And she got a nerve instead, and I had a vasal episode, and I passed out. Only happened one out of 80 infusions, and I was like, okay, because you're sitting there for 2.5, 3 hours, you're plugged up. And I like was like, I could be doing so much, like a manicure, a pedicure. I could be doing red light therapy. I could be getting a scalp massage for 3 hours. Like, there's a business model here. Like, if we go to these IV and these clinics for infusions for iron or your medication, which I need, I'd like to be doing something else too. Like make it like when a twofer. Like when you go to Disneyland, you also get to go to California. Here in LA. So I want more than just my infusion because,
Yeah, like when I do colonoscopy and do a bonus liposuction.
You could do that?
No!
Wow. I'm just saying. It could make it, because those clinics are like not the most, it's sad, And
No, I know what
sometimes,
you're saying. I mean, can you bring like a laptop and do work?
I did that, but then that's what got me in trouble with this vagal episode because I was trying to work and focus on getting a vein and it was too much. And sometimes, like when you go to UCLA, they've got these, like, if you sit in business class or first class, you know how you have these pods.
Yeah.
So they've got these pods, but the overall environment is very, and it's very heavy, it is, because some people are there for chemo, some people are there for iron. It's like a mix, right, of why people are there. I just wish we could offer these services. Like, hey, when you're there, do you want a mani? Do you want a pedi? Do you want a scalp massage? Just something to help distract you a little and get more benefit than just the medication. It's a dream of mine. What can I say?
You know what people could do is listen to podcasts.
Oh, yeah. Totally. They could listen to our podcast.
Yeah. I feel like listening to podcasts. Also, I know our infusion center sometimes has the emotional, like the pets, the support pets that walk around. They're the best.
I've never had, my friend Avery, she's no longer with us. She used to bring her dog. He was a joy. But yeah, just putting it out there, like add a little something. So it's more like, besides seeing our nurses who we love so much, because they're always a delight, just a little something to pamper yourself. I know it's a crazy idea, but it's a patient's wish. So
yeah, if you're out there listening and you run a surgery center, perhaps you could also get your esthetician's license, because we should be pedicurizing. No, I like it. I hear what you're saying. And these. Yeah, it's not the most enjoyable thing to be sitting there for 3 hours, feeling strapped to a chair, and you don't always have the energy, especially with chemo and things like that, to be reading a book or actively engaging in work or things like that.
Or sleeping. So there were a couple of times I was able to nap, but I would bring samosas to the clinic because I just wanted people to get excited about the food. Yeah.
If you brought a samosa to my endoscopy unit, I would do like a little happy jig, like a little elf or something, like do 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 do. A guy brought us bagels today. That was very nice.
Yeah. No, food goes a long way. My brother-in-law, who's a physician, he's all like, don't always bring donuts. Like, we get a lot of sweets. Like, bring us some savory stuff too. So
yeah, bring samosas. If you're getting your colonoscopy, if you're listening here and you're getting you should bring samosas to your gastroenterologist, because you would be like the king or queen of the day.
Yeah, I think you're coming here. I don't know when, but we got to do a little tour of all my favorite Indian eats when you're down here in SoCal. Okay, back to business. So you could do antibiotics, a diet, a cocktail of antibiotics, and then get a colonoscopy 6 to 8 weeks out. And is it like long term, or is it like small flares and episodes? Like, give me the profile of someone who's got a diverticular disease.
So for the most part, 30% of people will have recurrent diverticulitis. So if you've had it once, the chance that you have it again is low. 6 what is it, 70%. So, your chances are that you won't suffer again. But many people do suffer. And like I said before, if you have diverticulitis once, then twice, the chance keeps going up and up every time you have it. Like once you have it twice, the chance of you having it a third time is significantly higher. And so we talk about if you're doing all the right things, you're taking a fiber supplement, you're not constipated, the colonoscopy looks good. Sometimes people actually have to go to surgery because they have to get that part of the colon that keeps getting infected cut out, because if it just keeps getting infected over and over, the worry is that over time it can perforate, it can pop open, and that's obviously really bad. You don't want your guts spilling all over your insides. So we do many times refer patients to the surgeons if they've had what we call recurrent diverticulitis. And then, there is sort of this, I like to call it symptomatic diverticulosis. I'm not really sure if that's what it should be called, but especially in women and sometimes men, but our sigmoid colon, if it has a lot of diverticula, it sort of starts to change its shape a little bit. It's almost like because there's so many of these outpouchings, like it eventually kind of twists, like torques itself on its axis. And that can increase the risk of spasm, what diverticular spasm that you can get down in, especially there. So antispasmodics can be really helpful with symptomatic diverticulosis. So if you're doing a fiber supplement, you're not constipated, but you're still kind of getting like a lot of gas pains and left lower quadrant discomfort, especially after a heavy meal or before you've moved your bowels. Things like I think we've talked about IB-Guard, which is encapsulated peppermint. So that can be helpful. And even medications like dicyclamine, which is Bentyl, or hyoscyamin, which is Levsin, which are prescription antispasmodics. They're basically muscle relaxers for the GI tract. Those can be helpful to kind of cool things down and prevent a flare if it's starting to bother you, because you have a lot of diverticula, but you're not necessarily like on your way for surgery, because it's not that they're getting infected.
So literally it's spazzing like this. Remember in school we used to tell people don't be a spaz. So literally your muscles are spazzing. You give medication to tell it to relax, like a muscle relaxant. Okay.
Yeah. And even just the presence of diverticula, like especially when there's a lot of them, you can get this thing called SCAD, which is called segmental colitis associated with diverticula, SCAD, which we didn't really actually know about SCAD until, 20 years ago, 15 years ago. So there are some people that tell me, oh yeah, I was diagnosed with ulcerative colitis or something, and it actually wasn't ulcerative colitis. It was probably SCAD, which is where you can get a short segment of like redness and some swelling, which we call edema, right around like if there's like a big patch of diverticula, if you have a big sort of, why am I thinking of the word conglomeration? I don't know, like a bunch of diverticula all in one area. It can be like swollen and red just in that area. And the mainstay of therapy is, like I said, fiber supplementation, moving your bowels. But some people actually will need medications to treat SCAD, like medications that we use for IBD, like 5-ASA, mesalamine, and things like that. And also surgery could be indicated if you have significant inflammation there. So it's not totally benign, but it's really it can be really bothersome even if it's not infected.
Do you want to take a swig of a beverage? I was on mesalamine. I really, really, really liked mesalamine. It was a good drug, except we boosted it up during a flare, and I was at 1% that got pancreatitis, which bummer. It was a bummer. It was quite painful.
We haven't talked about the pancreas, have we?
No, we haven't talked. We haven't talked about it.
Damn pancreas.
What was it called? My lipase was through the roof, and I'm like, "What's a lipase?" The ER doctor's like, "I have to admit you and put you on an IV," and I'm like, for what? And he's all like, you have pancreatitis. I'm like, how did I get that? And he's like, we don't know. We have to look at all your meds. And they're like, do you drink alcohol? And I'm like, no, like I'm not
When I was in, so the two most common causes of pancreatitis in the United States, at least, are gallstones and alcohol. And there used to be, in med school, we're always trying to remember things, like how do we remember this? How do we remember that? And so
Yeah.
acronyms are really big. So one of the ones for pancreatitis was get smashed. Like, double
Ooh.
fisting at the bar, get
Yeah.
smashed for all the causes. It was like gallstones, ethanol, which is alcohol,
Alcohol.
trauma, like if you bang your belly on a steering wheel in a car crash, you can get pancreatitis. Salicylates, so 5-ASAs are in there, but also other kinds of medications that are salicylates. Mumps, yeah, you can get pancreatitis
Oh,
from mumps. I'm trying to remember what the other ones were. I don't remember.
get smashed. Got it.
Get smashed.
Yeah, it's quite uncomfortable.
Oh, scorpion sting. Scorpion sting was one of them.
Really?
Yeah, you can get pancreatitis from a scorpion sting. That's one of the S's.
Who knew? They were like, you must be a heavy drinker. I'm like, sorry to pop your bubble. I am not. And then we figured out it was mesalamine, and it's like 1% of people. So I'm like, yeah, good times. Yeah, good times. Okay, so
I guess we'll have to table the pancreas to season 2. The poor pancreas. It got no love this season.
it's okay. I'm working with this pancreas surgeon, a surgeon for the pancreas, liver, gallbladder. Maybe we can have a surgeon on next season as well. Because I'd love to know, what do you cut? How do you cut? And even what these pockets look like. Maybe you can like during here, Caro can insert what it looks like for us to see.
Definitely.
We'll get a visual so y'all can see what the pocket. This is not a pocket you want to style. This is not a pocket you want to have. We want to treat it. We don't want anything to be held except healthy pumping blood vessels and
I
no
would
bacteria.
show you my anatomy of colon. Can you see this?
Oh yeah, your cup. Put it up. Hold it up a bit more. Yeah.
Can you read it?
No, I can't read it. Send in a picture to Caro. Okay. The rest of us can read it, but read it to me.
It says, the atlas of a colon, just like life. Shit goes up, shit goes across, shit goes down, shit goes out. A patient gave me that as a gift.
I like that. Shit goes up, shit goes down, shit goes out.
Well, yep. Shit goes away.
I love it.
And that's basically it. It goes up, it goes across, it goes down, and it goes out. That's the colon.
Let me see if there's any other questions I had on diverticular. How do you treat it? No, we got it. So, and just to confirm, you can have these pockets anywhere in your esophagus, down all the way to your colon.
So if you have them in other places, they're less likely to get infected, right? Because like I said, stool is what's getting stuck in there, and your body doesn't make stool really until the colon. So it's much less likely for you to get them infected. That being said, it can happen for random reasons, but they're much less likely to be infected. But they can cause other problems, like people that have a lot of diverticula in the small intestine, for example, they're much more prone to SIBO, small intestinal bacterial overgrowth, just because stuff can get stuck in there and kind of sits around and ferments. They can bleed. So not that long ago, I had somebody have a pretty bad upper GI bleed from a small bowel diverticulum. And then if you have them in the esophagus, they cause problems because food gets stuck in them. So remember our episode of like GERD. So there's this thing. All I think about is like the little aliens from Toy Story.
From Toy Story. Yeah, Caro sent us that because she's editing GERD. And
I know. But back to the topic. So if you have, it's called a Zenker's diverticulum if you get it in the esophagus. You remember, like in medicine, we like to name things from either Latin or the people that discovered them. And Zenker's diverticulum are one of the rare causes of regurgitation. So like if you eat food, if you're eating a samosa that Sonia brought in for lunch at the surgery center, and then hours later you belch up potatoes and peas, it might have been because it's stuck in a Zenker's diverticulum and then it finally mushed itself out and came up. So it's one of those rare causes, and big Zenkers actually are problematic and need surgical correction and all these things. But, that's a story for another day. But they don't generally get infected. They just like ferment old samosas.
Oh, Zenker. So that's a Zenker moment when you regurgitate something.
Well, hopefully not, because they're not that common, but they are problematic when they exist.
What are you supposed to do when you regurgitate up food that didn't go all the way down?
I don't think there's any rule. I mean, you do.
Are you supposed to swallow it again? Or are you supposed to spit it out?
I mean, there's not like a law on that. What are you comfortable with? Do you want to swallow it again? Or do you want to spit it out?
I don't know. The next time it happens, I have to think deeply about it and make a decision.
It's all in how you're feeling that day, I guess. It's not, if your question is like, does it cause damage to re-swallow it? No.
Like when my nephew, he'll like drink out of a straw and then he'll spit the stuff back in. Like he'll
backwash.
Right back. And I'm just like, ugh. So I get one of those looks like, I'm not going to touch that drink. And I think he does it on purpose so no one can share with him, which is fine. That's its boundary, whatever.
Now I know how to steal your drinks. Just backwash them.
But like, yeah, what are you supposed to do when you've eaten too much at Thanksgiving or Diwali and then you're just like, that just reminded me of the dinner I had. What are you supposed to do? Dying question that I've always had. Dying to ask you.
I have no idea.
Your choice, in or out.
Yeah, dealer's choice.
Okay. All right. This has been a very helpful episode. Anything else, Dr. Soyka?
I don't think so. We'll leave it shorter and sweeter on this one. But I wanted to make sure we got it done because this is super common. And I don't even think I gave my favorite fact, which is 60% of people by age 60 will have diverticula.
60%?
Yeah. So that's why I'm like, this is super common. We need to talk about it. 60% of people by age 60, because it does increase with age. Because as you get older, the walls of the colon can get a little bit weaker. They lose their integrity a little bit. So as you age, diverticulosis, the rate of diverticulosis increases. So 60% of people by age 60 will have diverticula.
Anything we can do to prevent it?
We think a high fiber diet is helpful. The more pressure that you have on the wall, the more bulky the stool is, the less likely the pockets are to form.
Okay. Noted. Thank you.
All right. Well, thank you for joining me. Thank you for everyone who was listening this season. We had a really fun time, and we're really looking forward to season 2, growing with you, adding some guests that we can interview and specialists in all different areas. So we're already planning. So look out for that. And we're so excited to spend it with you soon.
Thank you, Dr. Soyka. See you later.
Thank you. Bye, Sonia.
Bye.